Hey everyone, welcome to the afternoon session, slightly before noon session of the periodontal complex and mineralized tissues. Thanks for coming. Sienna and I will be the chairs of the session. So let me kick things off. I'm going to tell you about our ongoing studies on hypophosphatasia. I and the other authors have no conflicts to declare. Hypophosphatasia, or HPP, is an inherited disease of mineralization that results in skeletal defects, including in severe cases, rickets, osteomalacia, and fractures. There's a number of mutations that have been identified, more than 400, and it's in the gene ALPL, which encodes for tissue nonspecific alkaline phosphatase. But there's a very broad range of severity that you can appreciate here. Some of these more severe cases can be lethal or very debilitating, where there's very mild cases, and even some cases labeled odontohypophosphatasia that affect primarily the teeth. Dental effects of HPP are also variable. What I'm showing here on the left is in order of how common they are. Cementum defects are very common across all types of HPP, which results in mobility and tooth loss, especially of the primary dentition. There are also bone defects that result in tooth mobility, malocclusion, dentin defects, and more rarely enamel defects. What we expect with primary teeth is that the normal pattern of exfoliation will look something like this, where the root becomes severely resorbed and the tooth falls out. But in HPP, because of these severe cementum defects, teeth often fall out way before they should fall out, often before 5 years old, sometimes as early as 1 or 2 years old, and they'll be fully rooted because of the very poor attachment to the teeth. Secondary teeth can be affected, but we don't really have a good idea how common that is. In a case report with collaborators Dana Gaddy and Larry Suva, we characterized an index patient who's a female child who actually had 2 mutations in ALPL, one in exon 5, one in exon 10. So she was biallelic heterozygous. And she had a childhood case of HPP that resulted in primary tooth loss of many teeth, shown here. And over the years, many mouse models have been developed to try to understand this disease, and they've been very helpful as far as understanding the pathology and the underlying mechanisms, as well as treatment effects. And some of those are shown here. But some of the limitations in mouse models are their size, short developmental time, bone physiology that's a little bit different than humans, and bone organization, and also that they only have one dentition. They don't have the primary to secondary transition. So with Larry and Dana, we talked about whether a large animal model could be useful for studying HPP. So using that index patient, we decided to work on a sheep model of the disease. Sheep were attractive because they had been used for some animal models before this. Their genome has been sequenced. They've been successfully used for other studies of inherited diseases, and they have a skeletal organization similar to humans. Also attractive to us for the dental side is that they have 2 sets of teeth, so we can look at primary teeth and secondary teeth. And what our focus here is going to be their incisors. So they do have a little bit unusual arrangement where they have a dental pad on the top, on the maxilla, but they have 8 incisors on the bottom that are going to be the focus of our studies. So we chose one of those mutations in the index patient, I359M. The other mutation hasn't been studied that frequently, so this was a more rare mutation that's not really well understood, how it's affecting mineralization. We were able to make 4 different genotypes, a wild type with the native I359, heterozygous, homozygous, and then a compound het that actually has one allele has the mutation and one allele had a larger deletion, so it's more severely affected. We saw that alkaline phosphatase enzyme levels were decreased in those models that carried the mutant allele. Looking at craniofacial tissues, we found when we carefully aligned them that the compound het, again the more severely affected, had a shorter craniofacial length. You can see here that it's not going to the line. And you can see measurements here. And slightly altered width and width-length ratios, although length was the most affected. Since the cranial base synchondroses can contribute to to craniofacial growth, we looked at the ISS and SOS, 2 of those synchondroses are shown here. And while we didn't find differences between genotypes, we found that in females, the synchondroses closed earlier than in males, which may have a relation to the smaller skull length in females versus males. Looking at the teeth, we saw a pretty striking phenotype. Sheep typically replace their primary dentition between 12 and 36 months, but in looking at the compound het, shown on the right, we started to see premature tooth loss as early as 2 months and increasing over 7 and 14 months. We also saw, and those missing teeth are shown by stars here. We also saw malocclusion in the incisors after they were losing teeth. And we saw that reduced alveolar bone, which we're showing by some vertical red lines showing the bone levels. Interestingly, we saw early eruption of secondary incisors in some of the mutants that had premature tooth loss. Looking at characteristics of the tooth loss, again, this is what I showed you before, premature tooth loss. And we looked at alveolar bone proper, which is the measurement we use to look at alveolar bone. This is the bone that's more closely related to the root surfaces. We saw decreased alveolar bone proper volume and density at 2 months, which slightly recovered by 7 months. So we were seeing bone defects as well. Looking at the teeth themselves, we saw trends in decreased crown length, suggesting enamel developmental defects or possibly erosion, and also increased root length. Also effects of dentin and volume. And the main trends we saw when we started looking at the composition of tissues were a mantle dentin defect, as well as absent cementum in the compound het. Histologically, we saw some trends in predentin thickness increase, which suggests delayed dentin mineralization, and trends in acellular cementum thickness. So conclusions are that we have a proof of principle creating an HPP sheep model, which recapitulates the range of severe to mild dental alveolar defects. Cementum especially was affected severely. We also see mantle dentin defects, which are interesting because they're not well described and may contribute to the tooth loss phenotype with HPP. So we see this as a model that we can go forward using novel treatments such as gene therapy or enzyme replacement, which is something that's under investigation now. Thank you, and I'd like to thank Fatma, who's done a lot of work on this, and she's going to tell you about some mouse models of HPP, as well as Michael in my lab and our collaborators, Dana and Larry, and I'm happy to accept any questions. Thank you. Okay.
Good morning. My name is Dr. Gyuan Hua from the University of Buffalo. The title of my presentation is Tris-tetraproline limits extension of monocytic myeloid-derived suppressor cells. There are no conflict of this study. Okay. Tris-tetraproline, in short TTP, is an RNA binding protein that regulates the immune responses that reduce inflammation by binding to cytokine transcript and promoting their degradation. TTP deficient mice exhibit severe inflammatory phenotypes, although they appear to be normal at birth. Importantly, TTP expression declined with age in all tissues. Thus, we will use TTP knockout mice as a model system to study age-related effect on TTP's influence on the myeloid cell biology. Myeloid cells of populations are key mediators for inflammatory regulation and immune response. Myeloid-derived suppressor cells, in short MDSCs, represent one of these myeloid population of cells that are known to expand during cancer, aging, and inflammation. Our group has recently shown that myeloid cells are expanded in TTP knockout mice, resulting in increased alveolar bone loss. Notably, we observed that monocytic MDSCs can directly differentiate into osteoclasts in vitro and in vivo. In this study, we present specific aim to explore the mechanisms by which TTPs represent the expansion of MDSCs that would occur during aging. With the global loss of TTP knockout, or loss in the myeloid compartment, conditional TTP knockout mice, MDSC was significantly increased in peripheral tissues, but not in the bone marrow. However, using a gain-of-function TTP knock-in mouse, we observed no MDSC expansion. This data suggests that TTP-dependent genes function to limit MDSC expansion and egress from the bone marrow. To understand which myeloid progenitor populations that contribute to MDSC expansion, a detailed flow cytometry analysis was performed. The percentage of total granulocyte monocyte progenitors, GMP, and monocyte progenitors, MP, considered as hematopoietic progenitor cells of MDSC were significantly increased in both conditional TTP knockout and TTP knockout mice. This result demonstrates that while no increase in MDSC was observed in the bone marrow, an increase in MDSC progenitor was observed in TTP knockout and conditional TTP knockout mice, indicating that TTP limits the expansion of MDSC progenitors. To understand the transcriptomic signatures at the level of individual cells without bias, we perform single-cell RNA sequencing in total bone marrow. As seen in UMAP in panel B, there are markedly difference in the distribution of control, conditional TTP knockout, and TTP knockout bone marrow. For further detailed identification with a focus on MDSC, we first label monocyte cluster from UMAP and recluster and identify 10 distinct subclusters. Based on the expression of MDSC specific gene panel, subcluster 4 was identified as MDSC populations. Although flow cytometry did not show a significant change in the percentage of MDSC, the transcriptomic profile showed a slightly increase in conditional TTP knockout mice and a greater increase in TTP knockout mice compared to control. Dot plot in panel E showing top differentially expressed genes within MDSC population, and it was notably different when compared to control in TTP knockout and conditional TTP knockout mice, including B2M associated with osteoclast formation. Since the progenitor cells of MDSC was significantly increased in the bone marrow, we analyzed the single-cell RNA sequencing focusing on the myeloid progenitor populations. The new dog-shaped UMAP show that the progenitor populations are continuously distributed. It was also interesting that among many branches, the early MDSC populations exist distinctly from the other clusters. Single-cell RNA-seq transcriptomic profile of MDSC progenitors were increased in conditional TTP knockout and TTP knockout mice than in control mice. Oops. Oh, I'm sorry, the computer has a problem. Okay. Since we determined that in the absence of TTP, similar to condition in aging, expanded MDSC progenitors were peripherally mobilized, we analyzed the expression level of key chemokine receptors mediating mobilization to MDSC and their progenitors in bone marrow. As shown in panel A, the expression level of CCR2, which plays a critical role in the mobilization of monocytes and their progenitors, was high in TTP knockout and conditional TTP knockout mice of the MMDSC progenitors. Importantly, there was no significant difference in the expression of CCR2 in the MMDSC populations. Computer is, yeah, okay. In summary, when TTP is reduced, similar to what is observed with aging, progenitors of MMDSC expanded in the bone marrow, and the expanded progenitors of MMDSCs are mobilized to the periphery due to the change in specific gene profile, including CCR2. Taking these data together with previous study from our group, demonstrating that TTP plays a critical role in alveolar bone homeostasis by directly regulating MMDSC expansion and mobilization. Although further studies are needed to apply these findings clinically, our studies strongly suggest that targeting TTPs or MMDSC may limit age-related pathological condition of the alveolar bone. I will thank to Dr. Keith Kirkwood and my lab members. Yeah, thank you, and I will entertain any question at this time.
Just to keep with the timing, what we'll do is we'll have questions at the end, just because we want to stay on time.
Next speaker is April Van Rensselaer.
Good morning, everyone. My name is Antita Panusuan. I'm PhD student from College of Dentistry, The Ohio State University. Today, I'm going to present about my research project, which is effect of sclerostin deletions on dental development and molar supereruption. So first of all, I want to talk about the background. So sclerostin is a protein which is encoded by sortin and regulate wind signaling pathway. It is expressed by osteocytes and cementocytes. From previous study, the deletions of source in mice cause alveolar bone and several cementum overgrowth, suggesting parallel regulation by osteocytes and cementocytes. So the mutations of sortin in human cause sclerosis and membrane disease. Diseases are classified by skeletal overgrowth and increased bone density. They show some dental manifestations which are mandibular enlargement, relative midfacial hyperplasia, partially edenturism, and delayed tooth eruption. So here we aim to investigate the developmental effects of source abrasions on alveolar bone and several cementum, and effect of unopposed supereruptions on alveolar bone versus cellular cementum. And we hypothesize that both alveolar bone and cellular cementum are increased and more responsive in the absence of sortin. So these are our methodologies. So we have two groups of mice, which is wild type and source knockout. And at 0 day post-procedure or 6-week-old of mice, we extract bilaterally maxillary first molar and for the developmental study. And moreover, we wait for another 21 days to induce supereruptions of mandibular first molar to gain more bone and several cementum. And after that, we euthanize the mice to collect data for microcity and histology analysis. And we use student t-test as our statistics. So these are the results for microcity analysis. So as you can see that no differences were found in enamel, dentine, bone, both volume and density. And these 2D and 3D images show the dental structure compared in wild type group and knockout group, which is similar in both group of mice at this age. And however, in the alveolar bone proper volume and basal bone volume, as you can see that in short knockout mice, we gain more significantly increased compared to the wild type group. However, interestingly, in cellular cementum, in both groups, there are no significantly difference at this age of mice. And this slide we show H&E staining comparing the wild type and knockout group. And as you can see that in knockout group, we shown in the below picture, the bone appears to be thicker with less marrow space in knockout mice compared to the wild type group in above pictures. And on the right side, as you can see that the green line dot label cellular cementum, they look similar in wild type group compared to the knockout mice. So at this age of mice, we can summarize that source knockout mouse molar at 6 weeks show no changes in enamel or dentine, and source knockout mice feature increased aura bone pulpal volume, but no change in cellular cementum. And the next question that we want to answer is, will super eruptions induce increased aura bone and cellular cementum or not? And we hypothesize that aura bone and cellular cementum are increased and more responsive in the absence of source after super eruption. And these are the results after super eruption at 21 days post-procedure. As you can see that in 21 days post-procedure, in source knockout we gain more significantly increased compared to the wild type group, and also in aura bone pulpal volume and basal bone volume. And these images represent the knockout group comparing the 0-day post-procedure and 21 days post-procedure. As you can see that we gain more bone volume compared to the in 21 day post-procedure compared to the 0-day, and which is consistent with the result that we got from graph at this age. However, surprisingly, in cellular cementum, at the 21 day post-procedure, in wild type group, we found more significantly increased compared to the source knockout. And the blue line label here, label here is labeled the cellular cementum structure which looks similar in wild type group compared to the knockout group. So from our experiment, we can conclude that sclerotin rarely regulate the periodontal tissue development in mice. Source knockout primarily affect aura bone development. However, surprisingly, cellular cementum show no developmental overgrowth at this age. So it's different from the result from previous study. And the super eruption induced robust aura bone formation, but the cellular cementum was reduced in knockout mice compared to the wild type group. So overall, scholars still rarely regulate the bone and cellular cementum differently. And for our further investigation, we will do proteomic analysis of aura bone and cellular cementum to see the protein list in knockout mice compared to the wild type group. So thank you for Dr. Brian Forster and our lab members. Thank you.
Do you have any questions? We have time for at least one. Okay, so I guess we'll just keep with the timing and we up next I believe is Natalie.
Excuse me, I actually have a question for. That is, my name is Wanida Ono from UT Houston. For your data, it says for a global knockout of the sauce global knockout. Have you ever take a look at the TMP sauce knockout or, other like Cree lines, so that you can, define the, deletion of sauce in either cementoblast or bone circs.
Okay, hello. My name is Natalie, and today I would like to talk to you about what happens to the periodontium when bone sialoprotein is deleted from neural crest cells. So bone sialoprotein, which is often referred to as BSP, is an extracellular matrix protein belonging to the sibling protein family. It is located in both the skeleton and dentition, including bone, cartilage, dentin, acellular cementum, and cellular cementum. For the purpose of this project, we focus specifically on BSP's effect on bone as well as the acellular cementum. BSP has roles in cell attachment, cell signaling, collagen binding, and hydroxyapatite nucleation, and it was because of its ability to precipitate hydroxyapatite that it was thought it had a role in mineralized tissue development. These hypotheses were supported when total deletion of BSP resulted in changes to skeletal and dental mineralization. The dental phenotype of these mice are shown here. And so before moving forward, we're just going to orient ourselves to the histo images for people who aren't familiar. So this blue line right here, that is acellular cementum located between the dentin and the PDL. And then detachment of the PDL is characterized by spaces. So this is a space between the PDL and the tooth, and then this black space up here. So now looking at the dental phenotype of total deletion of BSP, you can see that these mice had a reduced acellular cementum. They had periodontal breakdown, which was characterized by detachment of the PDL, as well as disorganization of the PDL fibers. Furthermore, you can see that the mice lacking BSP have less alveolar bone compared to their wild-type controls. So the results on the prior slide all occurred after completely deleting BSP from all tissues. We wanted to test the tissue-specific hypothesis that BSP, specifically in the ectomesenchyme, contributes to cementum and alveolar bone mineralization as well as periodontal function. So cranial neural crest cells, which are often referred to as ectomesenchymal cells, they act like mesenchyme and form most of the connective tissues of the head as well as the teeth and their supportive tissues, which are listed here. Okay, so the first thing we did was delete IBSP, which is the gene for BSP, from neural crest-derived ectomesenchyme using a Wnt1 Cre2 mouse model. The resultant mouse is referred to as a conditional knockout since BSP is deleted from some tissues, in this case the ectomesenchyme, as opposed to all tissues. Next, we collected mandibles at 2 time points, 30 and 90 days, to see the developmental effects of the loss of BSP. From there, the tissues were subjected to micro-CT as well as histology. So here we're looking at the micro-CT results for the 30 days time point. And so the first thing you can see in these two graphs is that the mineralization of the alveolar bone is less in the knockouts compared to the wild types. You can also see that the CKO mice had greater levels of bone loss, which is visualized in the furcation area, as well as at the bone plate. Furthermore, you can see that they had a widening of the PDL space here compared to the wild type controls. These are micro-CT results from the 90-day time point, so everything we just pointed out before is even more pronounced. So you can see that the mineralization of the alveolar bone is less in the knockouts compared to the wild types. And then you can also see that the bone loss is more extensive in the furcation area, as well as at the buccal and lingual bone plates. You can see the widening of the PDL space, and then at the 90-day time point, it's really good to see the loss of alveolar bone height. So in the wild type right here, it's a little bit shorter, and then in the CKO, the line is longer. It should be noted that using micro-CT, the effects of the loss of BSP from the ectomesenchyme were limited to the PDL and bone. For both time points, differences of the enamel and dentin were not significant. So following micro-CT, we wanted to further explore observations microscopically. So comparing wild type and CKO, you can see that the CKO mice with the H&E staining had a reduced acellular cementum, detachment of the PDL from the tooth, disorganization of the PDL fibers, as well as a thinning of the buccal bone. These are the results from the 90-day time point. So everything, again, as we just mentioned, is more pronounced. So they had a reduced acellular cementum. They had more expansive detachment of the PDL, greater disorganization of PDL fibers, and a greater loss of buccal bone. To further characterize our periodontal findings, we performed PIC-RO serous thread staining, which stains collagen to visualize the PDL fibers. So over here you have the 2 wild type time points, and you can see that the PDL fibers, they are nice and straight, they're organized, they're attached to both the tooth as well as the bone. Here with the two knockouts for both ages, you can see that there is detachment of the PDL from the tooth and then just greater disorganization of PDL fibers. So taken together, ablation of BSP from the ectomesenchyme contributes to decreased bone mineralization, thin acellular cementum, and PDL breakdown. All of these mimic what we see with the global deletion of BSP. So in conclusion, ectomesenchymal production of BSP is essential for the development and function of the periodontium. Thank you to members of the Foster Lab, the NIDCR, and to you for your kind attention.
Do we have any questions?
Hello.
Great talk.
Thank you.
So did you look at all at the cellular cementum, or did you segment the cementum out in the micro CT to look at changes in
We
volume?
haven't segmented it out from the micro CT yet.
Is there a reason why you're focusing on acellular versus cellular?
For the total knockout, acellular cementum was more affected than the cellular, so we
Okay.
just focused on acellular this time.
Okay. Thank
Good?
you.
Perfect, thank you. Okay.
Hi, my name is Sienna Perry, and today I will be talking about the role of collagen 6 in regulating the periodontal ligament structure and strength. Okay, so as you guys know, the periodontal ligament is important as it connects the tooth to the alveolar bone. And it's just important to understand that we need the periodontal ligament just for keeping the tooth secure in the socket, but also that the periodontal ligament also contains the osteoblasts and the osteoclasts, which are necessary for the formation and the breakdown of bone in the alveolar bone itself. And we want to understand, one thing that is important to understand is what actually gives the periodontal ligament this structure. This structure. So type 1 collagen is the major component of the periodontal fibrils. So as you can see in the electron microscope image, it's these fibrils, basically they make up what the periodontal ligament is. And the collagen fibrils are coming from basically these alpha chains that we have that form into triple helices. And just kind of, as you can see, you go from post-translational modifications to the actual triple helix formation, which then will assemble into these fibrils, which you see in the image. So type 1 collagen is not the only type of collagen that is located in the extracellular matrix, also in the periodontal ligament. We've also seen that type 6 collagen is one of the other collagens that is also located in mineralized tissue. So I'm going to go a little bit more into detail about this just for background purposes. So type 6 collagen is composed of 3 alpha chains, alpha 1, 2, and 3. And something to understand is that if one of these chains is not present, it will not actually form into, you will not have collagen 6 present, which means that you will not get the dimer and tetramer, which will eventually produce the extracellular bead that we see. So one of the things that we were questioning was that we understand that type 6 collagen is one of those collagens that can be located, and we were wondering, like, okay, is it actually located in the periodontal ligament, and if so, what role does it play? So first, to answer the question of is it located in the periodontal ligament, we conducted RNA scope and we also conducted immunohistochemistry. So as you can see with the RNA scope, though it seems it's not very highly expressed, we do see expression of type 6 in the periodontal ligament. And just to confirm that this mRNA is actually being it's going into a protein, we conducted immunohistochemistry, so we have the control, which has no primary, and then the Col6 one that has the primary. And you can see that in the immunohistochemistry that we do have the protein that actually remains in the periodontal ligament. So from here, we're understanding that we see it's in the periodontal ligament. So our next question is, if we were to knock out type 6 collagen, what would happen to the actual strength of the periodontal ligament? So in order to do that, we actually produced a type 6 alpha 2 knockout mice model. And with the help of Dr. Kim at the Ohio State, we were able to test the mechanical properties of type 6 collagen knockouts of the periodontal ligament. And so I'll just go through each of these graphs. So in graph A, what we're looking at is the loss of elastic stiffness, which specifically has to do with how well is the periodontal ligament able to resist the actual pressure that's being put on it. And you can see that though it's not significant, we have a trend that collagen 6 knockouts, periodontal ligament, is actually unable to resist as much compared to the wild type. Moving on to storage elastic stiffness, which is talking about the ability for it to actually store energy before the periodontal ligament is moving, you can see that it's significant that collagen 6 knockout is also unable to store as much of the energy that we're being put on compared to the wild type. And tan delta, which is the lost elastic stiffness divided by the storage elastic stiffness, basically is basically telling us that, okay, the knockout model is unstable in comparison to the wild type, and just leading to that conclusion that, okay, if it's more unstable, that means that the tooth is not as stable in the actual socket itself. So from here, understanding that, we were wondering if the actual strength of the periodontal ligament is weakened, what happens to the type 1 collagen that makes up the actual fibrils? So first part we wanted to do was actually confirm, like, okay, is the knockout of collagen 6 impacting the expression of type 1? And what we saw with RNA scope was that there is a trend in the decrease of expression in type 1 collagen. So when we were looking at the knockout versus the wild type, since we saw that, our next question was, okay, is it actually impacting what the fibrils are looking like in the models? So using second harmonic generation, we were able to show that there is disorganization of the type 1 collagen fibrils in the periodontal ligament for the knockouts. So if you look at the red arrows in the wild type versus knockout, what we saw was, as I said, there's a lot more disorganization, and then we also see that the width of the fibrils themselves are thinner. So that will explain like what we're seeing with that decrease in strength. So in summary, type 6 collagen is expressed in the periodontal ligament. The strength of the periodontal ligament was altered by type 6 collagen, was altered in type 6 collagen knockout mice. And then with the knockout of the type 6 collagen, we saw that it decreased the type 1 collagen that was being produced in the periodontal ligament, which led to the deregulation of the collagen 1 fibrils. So in conclusion, type 6 collagen likely has a protective role in the structure and function of the periodontal ligament. And I would like to thank my lab at NIDCR. I would also like to thank our collaborators at Ohio State. Thank you.
Very nice talk. Could you remind me again what kind of knockout it is?
Yeah, so what we did was, it was a type 6 alpha-2 chain knockout knife. So we knocked out the alpha-2 chain, so that, as a result, we just didn't have collagen 6 being produced at all.
And besides at the periodontal ligament, is it expressed in anywhere in other, tissue, like in body ligaments?
I'm not 100% sure, just because I am not completely focused on that. I know that in our lab we've also looked specifically at like the tibia, like the bone itself. I'm not 100% sure about that.
Okay, thank you.
Hi, great presentation. I just wanted to know a little bit about the mechanical analysis, if it was done under like a static load or a dynamic load. Thank you.
So I do believe that it was done under a static mode, so that we had a specific type of pressure, and then it was basically, I'm just like thinking about what exactly it was. It was at a static load,
Okay.
but, and then there's just like a little bit of a range between what it could be.
Okay, thank you so much.
Hi, great presentation. What do you think is the mechanism behind, like how does collagen 6 affect collagen 1?
So that's what we're trying to understand, and one of the things that we've seen is that we think there might be some sort of attachment that's going on between the type 6 and type 1, so then maybe as a result of type 6 being knocked out, you just have the structure of the actual type 1 collagen is not able to form as properly as it would be necessarily when collagen 6 is located there.
And one more question, like in the graphs you showed in the last 2 slides, were the differences statistically significant or there were trends?
Sorry, what was that?
The graphs you showed in your last 2 slides, were the differences statistically significant or they were
So
trends?
we still are, we're seeing trends right now because we need to get more data. So we're not, it's not statistically significant at this point, but that's because we need to get some more data as a result.
Okay, still very interesting. I was just
Thank you.
curious.
sorry. So I'm just, oh, so go to presenter mode down here. It should be good. Right there. Uh-oh. I tried to Here, hold on. Okay, I think that's good. Sorry. Well, hi everyone. My name is Ravi Masuria. I'm from the University of Minnesota in Minneapolis, Minnesota, and I'm a DDS candidate, and I'm in the oral biology program. And today I'm going to be talking about how female MEF2C knockout mice are osteopenic, and I have no conflicts of interest to report. So I want to start by saying that the human skeleton is overwhelmingly complex, and it provides the basis for many human functions, and they utilize various tissue types. Today I want to focus on two cell types in particular, osteoblasts and osteoclasts. So osteoblasts are notably as bone formation, and bone resorption cells are known as osteoclasts. And it's really important to create and maintain the balance because you need a harmonious balance that exists in a normal tissue type. So any ablation of that can lead to a lot of pathology. So normal bone can shift the balance to initiate formation or resorption because these processes are coupled. So if we look on the right side, higher osteoclast activity can lead to osteopenia, which can eventually lead to osteoporosis. And on the left side, if we look at higher bone formation rates, we can get bone thickening or osteopetrosis. So like I said, focusing on the osteoclast, this is a model for osteoclastgenesis. So what we do is we harvest bone marrow and we force the HSCs to go into multinucleated osteoclasts, and we can do that in vitro. So, and we can measure the activity and presence and differentiation of these osteoclasts based on various genetic factors and surface markers. So, a few different genes are involved in osteoclastgenesis, but one gene family, which is the MEF2 family, is really important in osteoclastogenesis. One gene type in particular is MEF2C. So our lab has previously studied MEF2A and MEF2D in bone resorption. However, the literature has not really investigated resorption, and especially in female mice. And so MEF2C and a lot of GWAS studies have highlighted the importance between bone fractures, healing, and bone mineral density models. So like I said, I'm going to be focused on the bone formation and bone resorption model for MEF2C. So what we first did is we created a CFEMS mouse, which has the conditional knockout for osteoclast, knocking out MEF2C. So just starting out with the standard Western blot from protein lysates, we showed that MEF2C is highly active at the beginning of osteoclastgenesis, and it kind of fades out as time goes by. But in the knockout, we've successfully knocked it out, and that MEF2C is actually not active at all, just confirming our conditional knockout. We also see downregulation of osteoclast markers, particularly in CJUN, NFAT, DC STAMP. It looks like the significant stars were not transferred over, but they are significant differences. Additionally, continuing the in vitro story, we see that deletion of MEF2C leads to smaller osteoclasts. So these are trap stains. So it's really important to notice that the number of the trap cells actually don't differ or from the wild type versus the knockout. However, the size does, indicating smaller osteoclasts. So now we're going to switch over into the in vivo model. So we did micro CT to see the phenotypic effect for conditional knockouts. And we show in the males there actually is not really any significant difference, but in the female mice there are. And you can also see there's increasing porosity, and the boundary is a lot thinner in the females. And so when you do bone volume over total volume, you see significant differences along with the trabecular thickness. So continuing the in vivo phenotype, we can also see that the cross-sectional thickness is also significantly different compared from the wild type and the knockout. And you can even see that it's a lot thinner compared to the wild type, and in the males there was no significant difference. So we also looked at, we did ELISAs to look at the trap, and type 1 collagenase. And you can also see another knockdown in the conditional knockout, or excuse me, a knockdown of expression in the conditional knockout for the females and not the males. And so once we took the osteoclast side, the bone resorption, we want to look at the bone formation side, so starting to look at the osteoblast. So this is something that we have just started. It's very preliminary. But when we did an ELISA on P1NP, which is an osteoblast marker, we're seeing that there's also lower rates of bone formation. And this is the same cross-sectional thickness, so also looking at the formation side is knockdown as well. So this data suggests that the osteopenic skeletal phenotype that we measured in female conditional knockout mice could also be related to the bone formation model. So just kind of a final discussion and conclusion, that despite seeing the genotypic evidence that female conditional knockout F2C mice should be osteopetrotic, if you can remember the smaller osteoclast size and the smaller, the knockdown expression of those traditional osteoclast genes, we should see an osteopetrotic data. However, when we look at the phenotype, we're seeing lower BV over TV, we're seeing lower cross-sectional thickness. So the genotypic data does not really match the phenotypic data, which is very interesting. And there's not really too much literature to explain this phenomenon or experiment mechanism, and the ones that have been published are mostly in the male phenotype because the papers have been confused about the female phenotype. In the future work, we want to explore sex-specific hormones and different molecular pathways that could be causing this difference, as long as bone formation models and maybe the osteoclast maturation pathways from the monocyte lineage. And I want to thank you all for being here, and acknowledge my PI and mentor, Dr. Kim Mansky, and the rest of the Mansky Lab.
I love experiments that are confusing. It's always really much more interesting. You're showing us that the size of the osteoclast is smaller. Do you suspect a problem in the fusion of the osteoclast? Because you know the osteoclast must fuse to increase its size, and that has, multiple nuclei. What's your opinion there?
Yeah, so we've done a few experiments with bone resorption discs to kind of see if they are doing chewing. However, it's been really hard to get them to work as they are. We just have to have it in a 96 well plate, and it's really hard to isolate. But that is in the future direction. We're also looking at some of those coupling factors.
Yeah, because if you think about your results, it could be that you're not resorbing and then releasing the growth factors that are needed for the formation. So I do think your coupling idea is very good.
Oh, yeah, so thank you. But I'll look more into that. Hopefully in the future I'll have...
There's not much known about fusion, actually. It's very mysterious.
Absolutely, yeah. Thank you for your question.
So we're going to move on. We can come back for questions at the end. So we're going to move on.
Hello, everyone. I'm Fatma Mohammed from Foster Lab from Ohio State University. So today I'll be talking about tooth defects in hypophosphatasia in mice due to ALBL ablation in neural crest cell lineages. A little bit background, so no conflict of interest. Hypophosphatasia is an inherited metabolic disease that's caused by loss of function mutations in alkaline phosphatase. And because of this mutation, the ALBL enzyme activity is very low in the serum. And this causes increase in the enzyme substrate, like in organic pyrophosphate. That's an organic pyrophosphate, which is very strong mineralization inhibitor. So basically, if we cannot inhibit the inhibitor, then we cannot mineralize bone and teeth normally. So very typical of this disease, patients lose their teeth prematurely within the first 4 years of life. So this because the teeth are lacking a cellular cementum, then there's no periodontal attachment to the tooth, and patients lose their teeth. With the root intact, no pain, no trauma. Other defects include thin dentine, wide pulpit chamber, and enamel defects. So for a growing kid, losing that many teeth could be stressful because it could affect the facial development, cause difficulty chewing, poor digestion, teeth are drifting, and misalignment. So currently, there is no established treatment guideline as whether this patient would benefit from orthodontic treatment or implants. So that's why we need to address this the treatment limitation. We want a mouse model. So here the ALBL systemic knockout phenotype with the severe and fatal HBB. So HBB has wide range severity, so this like the extreme severe. These mice show defects in the teeth. They have hypomineralization in the root. They show loss of the periodontal attachment due to lack of acellular cementum. But these mice, they have systemic complication. They die within 2 to 3 weeks after birth. So we cannot use this model to evaluate treatment. So here we developed mouse model using by targeting ALBL in neural cells using Wnt1 Cre2. And this is how we generate our mouse model. And this conditional knockout CKO, and we use the ALBL flux as a control. So results show that these mice have no difference in body weight. And they will look normal, and they have improved lifespan. That's advantage over the global knockout. They are similar to the HBV patient. They have low ALBL serum in the blood, but they show no difference in the calcium and phosphate. So looking at the teeth, here's a 2D and 3D micro-CT. So you can see the CKO mice have thin dentine and wide bulbar chamber. This is compared with the control. This is because significantly reduced dentin volume, but we don't see difference in the density. They also show defects in the alveolar bone. That's also been reported in HBV patient. And here in the mice, they show significantly reduced bone volume and density. Looking at the cellular cementum here down here, we don't see difference in the volume, but we do see difference in the density. For enamel that not being derived from neural crest cell, we don't see defects in the molar. Surprisingly, we see defects in the continuously growing incisor here. So you can see that the enamel is disrupted. And this is because significantly reduced enamel volume, but not the density. And just to confirm that this is not like to confirm the Cre specificity, here we perform ALBL in situ hybridization. So, and we found the Wnt1 Cre2 did not delete ALBL in enamel epithelium, as you can see here. And I think there's a good indirect effect because the disrupted epithelium mesenchymal interaction, as we saw defects in the dentin as well, like it's demonstrated by reduced volume, but no difference in the density in both tissues. For further characterization, here we first confirm efficient deletion of ALBL in situ, so you can see reduced staining. Looking at the histology, you see wide periodontate compared with the control. Here's the thickness quantification that shows significantly increase. So this is suggests delay mineralization. Also, they show loss of the periodontal attachment and lack of acellular cementum. This could be easily visualized by like color map here. You can see the cementum is missing in the CKO mice. That's also similar to what we see in the patient. So to confirm this finding, here we use a BSB and OPN as a marker for the cementum, but also we use the DMB1 as a for bone. So you can see these markers stain tissue very well in the control, but in the CKO mice, the staining is very low or faint, and it's not detectable on the osteoid. You can see here, that's unmineralized bone. So this suggests that there's defect in mineralization, and also suggests that ALBL is required for proper formation and mineralization in this tissue. So to summarize, here we developed mouse model that could help us evaluate the treatment. So first we target ALBL in neural crest cells in the teeth. This mouse model recapitulate HBB tooth defects, could be helpful with the improved lifespan. We can evaluate the treatment options and with the goal to improve the oral and dental health care. So here is my acknowledgement. Special thanks to my mentor, Dr. Brian Foster, and to my colleagues, and also for our funding, and thank you for your attention.
Hi, Fatma.
Hi.
Nice job as usual. So I just have one question. So how much do you think that this phenotype is totally explained by the effects on, pyrophosphate degradation? Or is it possible that there is some other effect of the ALP that's a enzymatic effect?
Yeah, I think could be both. So, like current state and in-depth knowledge how ALBL regulate the mineralization is still it's completely lacking. So currently we know it's like degrade the inorganic pyrophosphate. So unfortunately we cannot detect inorganic pyrophosphate in tissue. So it's like for technical difficulty. So we could measure the inorganic pyrophosphate in the serum, yes, but if it's this totally explain this phenotype, it could be partially yes, but there may be other mechanism as well.
Has anything been done with so I know that, therapeutically they have this, ALP conjugate that Jose Milan developed.
Yes. Mm-hmm.
So has that been tried at all to see its effects on the
yes.
tooth?
So yes, there's studies out there where they try using the recombinant enzyme replacement therapy with the 10-aspartate amino acid, and this shows significant improvement, like in the dental defects, but also as well as like in the patient. They like it was a huge success for severe cases, but for dental hypophosphatasia, it's kind of limited to severe cases. So this is kind of mild form of HPP. Sometimes the patient doesn't qualify for the treatment, so that's kind of downside. And plus the treatment, the reason why they have it for the severe cases because the complication of the treatment. So currently there's no established, it's mostly supportive, like treating patient is mostly supportive, but no established treatment like for dental HPP. So for like the current knowledge, like we know that hypophosphatasia hydrolyzes the inorganic pyrophosphate. It's also important, we know from like the in vitro study, important for differentiation, but how this can translate like in vivo, why these teeth are lost prematurely. So all these kind of questions, like the root is whole contact, no pain, that's kind of surprising for me. I think that's like most interesting aspect of the disease. So yeah, I think there's like more space for like more investigation to be able to understand the mechanism specifically. For this model, I think it's the interesting thing is that with the improved lifespan, it also is specific for the teeth. This kind of limits the systemic complications, so that doesn't interrupt with the affect the like interpretation of the results. Mm-hmm. The other thing that I think we want to use this model for early versus late intervention of the treatment, which cannot be done with the global knockout.
Okay, thank you.
One more? We're done. I'm not so. Okay, thanks.
Up next we have Kelly.
Okay, hello everyone. My name is Kelly Dwan, and I'll be presenting today on my research along with Zora Kim and then our PI, Dr. Kim, regarding alveolar bone mineral density in women with aging. Also, I'm a dental student from Ohio State College of Dentistry. So all authors have no conflicts of interest to disclose. So just to briefly introduce our subject, I have a couple of studies here. So epidemiological studies have historically shown that there's been a higher prevalence of tooth loss and edentulosum among women compared to men. And while that disparity is diminishing in the States, many other countries around the world still maintain that disparity. And there's another particular study that has come to the conclusion that women having fewer teeth compared to men could be related to bone turnover rate, socioeconomic status, as well as use of estrogen hormone therapies. And in addition, women with postmenopausal osteoporosis are showing a higher risk for decreasing bone mineral density, or BMD, as well as a higher in their orthopedic bones. And that could result with estrogen deficiency starting at menopause, as well as reduced bone formation. But this relationship has not been studied extensively in jaw bones and the oral cavity. So here are just some of those studies. So this is data coming from the NHANES survey showing the prevalence of complete edentulosum in adults 65 years and older. And as you can see here, historically, women have had a significantly higher prevalence of tooth loss compared to men. And this is another graph from another study showing a number of teeth in adults older than 50 years old. The white column indicates males, gray column is postmenopausal women without hormone therapy, and the hatched column is women with hormone therapy. So as you can see, the postmenopausal women without estrogen or hormone therapy are showing more tooth loss compared to males. And as that tooth loss in women seems to be related to the use of estrogen therapy, then there could be some sort of relationship between tooth loss and osteoporosis in these women. So that brings us to our study. The objective of our preliminary study is to examine whether that oral bone mineral density, or BMD, changes differently between men and women with aging. Okay, so going into our methods, this is just a general summary. We retrospectively obtained CBCT images from 78 different patients within our College of Dentistry. The population includes 37 males, 41 females, assigned to 3 different age groups, shown here. These age groups were split up this way to investigate premenopause, menopause, and postmenopause. And then we focused on mandibular left first premolars, number 21, and we followed a heuristic algorithm in order to digitally isolate those teeth from the CBCT images. So we are able to isolate alveolar bone, which was 1 millimeter from surrounding the tooth roots, and then basal cortical bone that was 6 millimeters from the mandibular bone borders. From there, we looked at gray values of each of those bone voxels, which was proportional to the BMD, and looked at that on histograms to assess mean standard deviation, and follow through with data analysis using Pearson's correlations and one-way analysis. So here's just a visual example showing a tooth root at the top, and then on the lower left, we have the alveolar bone region that immediately surrounds the root, and then the cortical bone region on the lower right that is nearing the mandibular borders. So this is just kind of an overall summary of how we go through the algorithm. So we first start with a full CBCT TIFF file. We crop it to include the entire root of number 21. And then using this software on the bottom left, we can manually outline the tooth root slide by slide on the CBCT to separate it from surrounding structures. And we check it on each of the different cuts to ensure accuracy. So as we continue through the methods, we can separate and view our desired tooth gray voxels, the surrounding bone gray voxels, cortical bone, and alveolar bone. And then using more like ImageJ and other software, we can obtain these histograms that show us the gray value and hence bone mineral density of the cortical bone and alveolar bone regions of each of our samples. Okay, and then after compiling and analyzing all of our data, we discovered that the mean gray values of alveolar and cortical bone regions were not significantly different between the age groups of male and female groups. And the majority of the correlations during our Pearson's correlation tests were also not significant. However, we did find that only the alveolar bone region of the female group showed a significantly negative correlation between mean gray value and age. So this is meaning that as women are increasing in age, they are decreasing, they're showing a significantly lower bone mineral density. So here's just some graphs. This is mean gray values of each age group for men and women for alveolar bone. And again, we're seeing women showing a significant decrease in mean gray value with increased age, specifically with the dramatic drop between the 40 age group to the 50 age group, which is indicating menopause. And then this is cortical bone. Generally, cortical bone didn't show significant changes with aging, stayed pretty stable. And then this is just some correlation tables. Men, there were no significant correlations between BMD and age, but with women, we found a significant decrease in alveolar bone mineral density with increased age. So in conclusion, this negative correlation is showing us that as women are increasing in age, their alveolar bone mineral density is decreasing. And as that alveolar bone is the bone that directly surrounds the teeth, it suggests a potential mechanism for why there's a higher risk of tooth loss found in women compared to men. And this further suggests possibly the ability to use clinical CBCT for BMD analysis and ultimately to improve diagnosis and treatment planning for these at-risk groups. Okay, so these are just some references. Thank you so much for listening, and I just want to acknowledge Dr. Kim for all of his support in all of this. Thank you.
So as I mentioned before, we'll come back to questions at the end just to keep with the schedule, but last we have Victoria.
Okay. Hi, everyone. My name is Victoria McGlaris, and I'm a third-year dental student at University of Buffalo School of Dental Medicine. I'll be presenting my work towards a standardized bone microarchitecture analysis of alveolar bone. We have no conflicts of interest to disclose. So currently, microcomputed tomography for use in assessing trabecular bone morphologies in alveolar bone is growing, and there are numerous softwares and studies that are trying to look into that. However, no validated method exists in order to quantify the alveolar bone. So the objective of this study was to develop a standardized and reproducible histomorphometric methodology. Through this, I wanted to assess also reproducibility through inter-rater reliability comparisons, as well as further taking that into assessing variance between any differing results in region of interest selection. An overview of our method: 70 posterior regions of the rat maxilla were scanned in the Scanco Medical Micro-CT 100 scanner at 16 microns. They were imported into Analyze Pro, where they were opened in Transform in order to orient and crop the sample to obtain the regions we desired. They were then opened in Segment to establish our region of interest that would be used in our BMA, or bone microarchitecture analysis. So the object was then thresholded to extract it from the background, and using the buccal view and the CEJ of the second molar, we were able to locate a slice and translate that apically and create what would be defined as the wider cylinder, and you'll see why later. Then the distal periodontal ligaments of the two distal roots of the second molar were identified to orient the cylinder in another direction, in the X and Y direction. And that was translated mesially, and then the cylinder was shrunken to our desired final shape. To briefly overview how we oriented and cropped the scans. So first, we aligned it using the CEJ of the second molar in both the sagittal and coronal planes as a way of orienting it so that we kind of had horizontal orientation of all CEJs of the first, second, and third molars. Then to crop, we would scroll through in each direction or in each plane, axial, coronal, sagittal planes, to ensure total and capturing of all tooth structure and periodontal ligament structure. As seen in this green box, then we extended that region in 10 by 10 slices in the positive and negative direction in each axis. So as mentioned, I wanted this to be reproducible, so we were using anatomical landmarks to do that. Again, using the CEJ, the most apical portion of the CEJ was identified of the second molar to determine the center Z coordinate of our cylinder. That was then translated apically by a certain number of slices where you would come to this cross-section. So you would use this to identify the location of the cylinder by contacting the periodontal ligament spaces of the two distal roots of the second molar. That would then determine our X and Y coordinates of the cylinder. So then the cylinder was shrunken and again shifted mesially, as I mentioned earlier. Further, to do the BMA analysis, you would create that cylinder and threshold it. In order to assess the trabecular thickness and space, you would add the BMA template where you assign one cylinder, the non-thresholded one, to intratrabecular space and the thresholded to trabecular bone. You open the BMA analysis and you're able to measure the thickness and space, which then I used to help perform the kappa correlation to assess the inter-rater reliability. I just wanted to highlight the region of interest. As you can see, that cylinder, green and yellow, is completely encaptured in interradicular bone, which is what was desired. We didn't want it to interfere with any PDL space or even interfere with any cortication. And the final dimensions of the cylinder were a 15 slice radius as well as a 50 slice height. You can observe in yellow the intratrabecular space as well as in green the bone. So 3 users performed this method on each of the 70 samples that we had scanned, and I determined in kappa that our P of chance, or the chance of each user agreeing, would be 1/3, and allowing for a plus or minus 1 slice from the actual CEJ. Then I just chose 3 samples to show each kind of case scenario. So in one sample, in sample 1, you can see each user agreed in every dimension or location of the cylinder in each X, Y, and Z coordinate. So the P, or the kappa value there, was 1. In sample 2, you can see in X that there was I don't know if I can highlight. Okay, there. There was a difference in 1, so that allowed for agreement because that was within our P chance of plus or minus 1 slice from the actual. And then you can see in Y, there was a greater than 1 deviation. So following the equation shown on the left, or your right, that corresponds to a kappa value of 0.5. So for each X, Y, and Z, the kappa values were calculated and then averaged for all 70 samples. For the BMA analysis, again, the 70 samples and the region of interest as defined in the previous slide were used, and they were assessed for variance. So we wanted to see, okay, if there was a slightly different region of interest identified, will our results or trabecular thickness and space vary significantly? And I used the same 3 samples here, so when there was perfect agreement, there was no variation, and very small variations when there were differences in the region. So the results for the kappa values to show reliability and agreement, each X, Y, and Z coordinate was over 0.9, and I want to highlight the Z coordinate corresponded to identifying the CEJ, so that was it was good to see that every user was able to recognize that landmark. And then in variance of BMA, as mentioned, we identified very small variances between 0 and the biggest variance was 0.0049. So in conclusion, obtaining kappa values over 0.9 indicate high reliability of the method as well as a high level of agreement between users. And there is promise in the development of a valid methodology for the analysis of the rat maxilla bone morphology. I want to identify some limitations. So for this study, we just kept the orientation and the cropped portion the same throughout users, just to be able to identify, okay, can the users identify these landmarks and keep at least one thing constant? And we only used one software program, which was Analyze Pro, and that leads to the future of hopefully looking at this method in use in other software programs to see if it's applicable and broaden its range, as well as looking at other animal models. And I would like to acknowledge the University at Buffalo Office of the Vice President through their Buffalo Blue Sky Initiative, as well as Dr. Piasecki for her help in obtaining these beautiful micro-CT images. And I will take your questions.
And also now we're able
question.
Yes.
Have you had a chance to use this on any models where you expect the bone to be different so you can kind of test the sensitivity to detect changes?
So this was just done as a methodology study, but we have looked at its use in mice, but not specifically for any gene. Like the rats that we have all different morphologies. So it's just to see, is this method reproducible? Go for it.
Victoria, I think you like mathematics.
I do.
From a, running a lab point of view, how much time does it take for someone to learn how to do it? Like you've had 3 users. What's your feeling about how much time do they need to, how many hours, let's put it that way?
Okay, so most of the time actually is in the analysis of it rather than learning. So I used all users with different experiences with micro-CT, if not any. So just based on how the method was written, they were able to follow it and probably learn how to use it within, I'd say, an hour or so. But to actually conduct the analysis and establish your regions and everything, that takes a lot of time. So I'm very grateful to my 2 other users for dedicating hours and hours and hours.
Any other questions?
Hi there. That was an interesting talk. So I have a couple of questions for you. First, when you're examining MDSCs, which are immunosuppressive in function, what was your rationale to look at their ability to differentiate towards osteoclast?
Yeah.
Because their primary function is to suppress the immune activity in the niche they're present. And my second question is that TTP, given its role in the RNA decay, it's an important protein that mediates the overall transcriptional activity in the cell. Do you think RNA-seq approach would be an ideal strategy to see the overall changes in the cellular transcriptional landscape, because it's so critical to overall transcriptional output in the cells?
So firstly, we also checked the MDSC population that it acts as a immune suppression. So let's see. So we are focusing on the MDSC as a precursor of osteoclast. So we check the immunosuppression to check that population is real MMDSC population, but yeah, we are focusing on the MMDSC as a osteoclast precursors. So yeah, when we do the you said about TTP is related to the degradation of the many cytokines. So yeah, so we focus on the MDSC. So we're using a model system. So and yeah, I think there's no problem using that kind of things like RNA sequencing or something like that. But this study, we are focusing on the single-cell RNA-seq. But yeah, it is like we saw just transcriptome profile. So in this study, so I think there's no problem about it.
Okay. Thank you.
I think it's Natalie that presents. Is she here? Yeah. You did the BSP study, is that correct? Yeah. So I was wondering if you had the chance to look in your animals with the BSP knockout, if there's any alteration of specific proteoglycans in PDL, for instance?
We have not looked now.
Okay. I just wonder, I mean, it seems to me maybe like you're messing with BSP, which favors mineralization, and then perhaps a protein like aspirin, which blocks mineralization, may be altered. And this
Okay.
kind of protein may actually explain your phenotype there with the collagen.
Okay.
Yeah.
That's a good thought. Thank you.
Okay, sure.
Okay.
So let me make sure I understood. So the experiment was that you depleted BSP in the neural crest when producing cells, right? Is that the idea?
That is correct.
You know, there's all these public databases out there. How early is BSP actually expressed? Because your premise would be then that BSP should be expressed at that early age, because you're knocking it out at an early age.
Right.
What's the story?
I don't know like the exact time frame. I think it's fairly early. Correct? Yeah.
Okay. I guess it must be in Wnt producing cells though, right? Because that's what you knocked it out. Okay.
Mhm.